Hello, everyone, and good morning. Welcome to another NCLEX review with Alex. My name is Alex, and I'm very thankful to have you all here. What we're going to do is we're going to go ahead and open up in prayer, and then we're going to talk about your homework from last week. We're going to talk about what we're going to be learning today, and then we'll get started. Let's go ahead and open up with a word of prayer. Our dear Heavenly Father, Lord, thank you so much for waking us up this morning. The fact that we're alive and breathing and not in the hospital is a blessing. Father God, please bless all of my students. Bless our children. Bless our family members and loved ones. Father God, I pray this will be the year that my students will all pass the NCLEX. Every single person in this class right now, I pray that you help them to pass and get their nursing license. I pray that they would be positive and optimistic that it's going to happen, and it will. In Jesus' name, amen. Good morning, everyone. So, last week you were supposed to read chapter 1 in your study guide. Also, I suggested that you get a Q bank and that you do 25 to 50 questions on the subject that we learned, which was foundations. So, also, I provided you with the link to the flashcards as well so that you can practice your isolation precautions. Finally, you are supposed to be watching the isolation precautions video every class. So we're going to watch the isolation precaution video towards the end of class today, but please make sure that you are watching it every day and that you are repeating your isolation precautions. Today, what we're going to be doing is we're going to be learning our lab levels and our electrolyte levels. This is very important for you to pass the NCLEX, so do not neglect this. Also, class is going to end a little early today. I do have an appointment that I could not cancel. However, to make up for it, I'm going to be sending you all some questions to do on Thursday. So, Thursday morning, 10 a.m., I'll send it out in the WhatsApp group. And you can do those questions, and those questions will help you to review what we're going to be learning today. Okay. So, let's go ahead and get started. So we're on page 66 in your study guide, and we are on labs and electrolytes. So the first section is your ABGs. ABG stands for arterial blood gases. These labs are basically going to tell you how much oxygen is in the blood. It's going to tell you if your blood is too basic or acidic. And I want you to know that a patient in severe respiratory distress, they're usually going to get their ABG levels drawn. Okay. So memorize that a normal pH is 7.35 to 7.45, a normal PaCO2, which stands for partial pressure of carbon dioxide, is 35 to 45. A normal bicarb is 21 to 28, and a normal partial pressure of oxygen or PaO2 is 80 to 100. Hematology is going to tell you how many red blood cells, white blood cells, and platelets are in the blood. Also, it's going to look at the red blood cells and evaluate the concentration and oxygen carrying capacity. So, normal red blood cell count is 4 to 6 million. Normal WBC count is 5,000 to 10,000. Normal platelet count is 150,000 to 400,000. So usually when people say like, what's the red blood cell count in the hospital, we'll say like 4 or 5 or 6. We don't really say like 4 million, 5 million. It's kind of inferred that we're talking about million. So memorize that. For white blood cell count, you can think of it as WBC, will by car. So think of the normal white blood cell count as the down payment for a car. You usually put down $5,000 to $10,000 to buy a car. Okay, so will buy car. I will buy a car with five to $10,000 down. Then platelet count, I think of if you get like, Haitian women, we love to buy like fancy china plate sets. So I think of a fancy plate set and that you bought the house to put the plate set in. So when I think of platelet count, I think of like a cute plate set, and I bought the house to put the plates in, and the house, I wish, 150,000 to 400,000. So that's how I remember that. Okay. Then hemoglobin and hematocrit. So hemoglobin, it talks about the oxygen carrying capacity of the blood. For a female, it's usually 12 to 16. For a male, 14 to 18. Hematocrit is the concentration of the red blood cells. So when you take a sample of blood and you put it in a vial and you put it in a machine that spins very quickly, which is called a centrifuge, the components of the blood will separate and you'll have plasma, you have a white buffy layer, and you'll have a layer of red blood cells. So that layer of red blood cells, the amount of it, the concentration of the red blood cells compared to the plasma, that's called hematocrit. So hematocrit is usually 3 times the level of the hemoglobin. So a normal hematocrit for female is 37 to 47, and normal hematocrit for male is 42 to 52. Some other things that you need to memorize is neutropenic precautions and bleeding precautions. So for homework, I want you to read the different components of it. It's very important that you know. So neutropenic precautions is for someone with low neutrophils, and this places them at high risk for infection. So make sure you memorize that. Then you have bleeding precautions. This is for someone like on blood thinners, like for example, that are taking Coumadin or warfarin. And so please memorize those different components to that precaution. Coagulation studies, you have APTT, PTT, PT, and INR. APTT should be 30 to 40. PTT should be 60 to 70. PT should be 11 to 12.5. INR should be 1 to 2 for a normal individual. However, if they're on Coumadin, it should be 2 to 3. PTT is for heparin. PT-INR is for Coumadin. One way that you can memorize memorize that PTT is for heparin is the 2 T's. If you put a line through it, would make an H for heparin. Okay, so that's how you can remember that. PTT is for heparin. So when somebody is receiving heparin, as a nurse, you will monitor their PTT. If somebody is on Coumadin, you would monitor their PT and INR. APTT and PTT, you can monitor either one for heparin. The difference between APTT and PTT is that the APTT has an activator added into it, so the test runs quicker. That's what the A stands for, activated. So between APTT and PTT, you could use either one to monitor a patient on heparin. However, APTT is more sensitive to it. So APTT will be the ideal coagulation study to monitor for in a patient on heparin. All right. So this is something that you're going to have to watch again when I send out the recording, because this is something very important for you to understand. Then we have our serum electrolytes. We have our sodium, our potassium, calcium, magnesium, phosphorus, and chloride. Sodium 135 to 145, potassium 3.5 to 5.3, calcium is 9 to 11, magnesium is 1.5 to 2.5, phosphorus is 2.5 to 4.5, and chloride is 95 to 105. Your chemistry values, glucose should be 70 to 110. Hemoglobin A1C or glycosylated hemoglobin should be 4 to 6%. BUN 10 to 30. Creatinine 0.5 to 1.5. And cholesterol should be below 100. Excuse me. Cholesterol should be below 200. My apologies. Then you have your urine specific gravity, which should be 1.005 to 1.030. Some other books say that urine specific gravity should be 1010 to 1030. So I found that that one is so much easier to memorize. Urine specific gravity 1010 to 1030, right? Also, keep in mind that every book has different normal levels for labs. Every hospital you work at will consider, like, for example, I worked at two Advent Healths. I worked at Advent Health Orlando. I worked at Advent Health Sebring. At Advent Health Sebring, 3.5 was normal for potassium. So if the patient's potassium was 3.5, we didn't have to do anything. It was normal. But at Advent Health Orlando, 3.5 was low and we had to replace the potassium. So every hospital you work at will have different normals. Okay. And so you will learn them on orientation. Okay. All right. So let's keep going. The next page, and let me see if I can make this a little smaller. So the next page has your normal vital signs, okay? So normal temperature, 97.5 to 99.5, normal pulse, 60 to 100, normal respiratory rate, 12 to 20 breaths per minute, normal blood pressure, the systolic should be at least 90 and upwards to 140. Oxygen saturation should be 95 or above. Okay. So these are things that there's just no way around it. You'd have to memorize it. All right. Page 68 has what's the beginning of the electrolyte cheat sheet. Okay. So it highlights each electrolyte. So make sure for homework, you have to read this entire chapter. This chapter is essential for you to pass the NCLEX. Okay. So it's not enough to just watch this lecture and to read your notes. You have to read chapter 2. So, what is an electrolyte? An electrolyte is a mineral that carries an electric charge when it's dissolved in a liquid such as water. And guess what blood is mostly made out of? Water. Okay. So, when an electrolyte, which is a mineral, is placed in a liquid like water or blood, it separates and it can either bear a positive charge, which would make it a cation, or a negative charge, which would make it an anion. Okay. Serum electrolytes, that means that you're measuring how much of an electrolyte is in the blood. So for each electrolyte, we're going to go through a profile of it and talk about when the electrolyte is too low or too high. Long story short, potassium is one of the most important electrolytes for cardiac function. You need potassium to be normal for healthy cardiac function, muscle function, nerve function, and renal function. Okay. And remember, this is recorded, so you'll be able to rewind this so that you can take notes. Okay. But just another kind reminder, electrolytes are important, they are essential. You will have to watch this recording again. You will have to read the entire chapter. So normal potassium level is 3.5 to 5.3. What do I want you to know? Hypokalemia is potentially life-threatening. Hyperkalemia is potentially life-threatening. So, as a nurse, especially if your patient is in the hospital, you should be looking at your patient's potassium level every day that it's checked. So, whenever that lab level comes in, or if it's available to look at, you should look at it. When potassium is too low, it leads to something called PVCs, premature ventricular contractions. The danger in that is that PVCs can turn into VTAC and VFib. Okay, so that's why it's so important to monitor the potassium level. So, what can cause the potassium to drop? Diuretics, especially diuretics like furosemide, bumetanide, and torsemide, vomiting and diarrhea, NG suction. Okay, so those are the major causes. I want you to memorize the EKG changes associated with hypokalemia. There's three major ones: ST depression, a flat T wave, and a U wave. The treatment for potassium, it's given in milliequivalents. Some people call it MEX, but I don't like that. So, for example, potassium is that comes in like 10, 20, 30, 40, 50 milliequivalents. So, how much you give depends on how much is ordered. And how much is ordered depends on how low the potassium is and the creatinine level. Never, ever, ever forget when potassium is low, it's kind of like a negative bank account. When the bank account is negative, you put more money in. Excuse me, I don't know if I'm having allergies or anything, but like my whole nose like just keeps bothering me. But anyways, so a low electrolyte level is kind of like a low bank account level. The way to fix the bank account level is to put more money in. The way to fix hypokalemia is to give potassium. However, before you give potassium, you have to check the creatinine because creatinine is an indicator of kidney function. If the kidneys are not working properly and you give potassium, you're going to lead to hyperkalemia, which can stop the heart. Okay. So before you give potassium, there's two things you're going to check. You're going to check the potassium level because it has to make sense of why you're giving the potassium. And you're going to check the creatinine level. And remember, a normal creatinine is 0.5 to 1.5. So once you've got your potassium level and the creatinine level, and it matches with the requirements of the order for the potassium replacement, you have to memorize for potassium, we don't rush it, we don't crush it. We don't rush it, which means we don't give potassium quickly. We do not give IV potassium quickly. And we don't crush it, which means any oral form of it, we can't crush it. So if you're giving it IV, you cannot rush potassium. If you're giving it oral, you can't crush it. Potassium IV, you can't rush it. Potassium oral, you can't crush it. Okay, so oral, it comes in liquid and tablet. Liquid, it tastes disgusting, mix it with juice. Tablet, the tablet is very big. So if your patient can't swallow, tell pharmacy or the doctor so they could switch it to IV. Okay, or the liquid. So the tablet is really big, but you can't crush it. If your patient has a PEG tube, you can't crush the potassium tablet. Ask pharmacy for the liquid. IV, you never rush it. So you can't give it IV push. You can't give it bolus. You can't give it fast. You need to give it with an IV pump. You give it slowly over 1 to 2 hours. IV potassium burns, so you have to give it slowly. You can also give it as a Y infusion, which means they're getting the potassium slowly through one line and they're getting like IV normal saline slowly so that it mixes and it dilutes it. Next up is hyperkalemia. Hyperkalemia, some major causes, maybe they're getting potassium sparing diuretics. So you have the diuretics like loop diuretics, right? Loop diuretics like Lasix, Bumex, Demodex, your furosemide, your bumetanide, your torsemide. Those diuretics drop potassium. But there's another class of diuretics called potassium sparing diuretics, and that is aldactone, which is spironolactone, and amiloride, which is mitomor or metamor, some people say. So spironolactone and metamor are place the patient at risk for increased potassium. Another major cause of hyperkalemia is kidney disease, like chronic kidney disease, end-stage renal disease. So your patients with kidney failure and who are on dialysis are at high risk for hyperkalemia. Make sure you memorize that. The three EKG changes that I want you to memorize are going to be a flat P wave, a wide QRS, and a tall T wave. So you've got some homework to do. The treatment for hyperkalemia. So, treatment options for hyperkalemia. Here and here. Okay, so we can give sodium polystyrene sulfonate, which is Kayexalate. So this is oral. It's usually a powder that you mix with juice or water and have the patient drink it, or it can be a rectal suppository. So two things. Kayexalate is going to take time because it has to go through the gastrointestinal tract. Also, it causes diarrhea. So those are the two things I want you to know about that. If we have an emergency and we need to get the potassium under control a little bit more quickly, so to speak, we could use regular insulin with dextrose. We know that insulin is like a key that opens the door to the cell. So insulin will open the door to the cell and it will take potassium in. And that's going to help fix the hyperkalemia. Unfortunately, it's also going to take blood sugar with it. So that's going to drop the blood sugar. So that's why we also give it with dextrose. Okay. So memorize the EKG changes for hypo and hyperkalemia. Memorize the treatments. For hypokalemia, it's low, so we're going to replace it, but we need to check the potassium level. We need to check the creatinine level. When the potassium is low and we're giving potassium, remember, don't rush it, don't crush it. So remember, don't rush it if it's IV. No IV push, no bolus, no pushing it fast. We give it slowly over 1 to 2 hours. Remember, IV potassium can burn, so we give it slowly, and you could give it as a Y infusion with normal saline running at the same time. For for potassium replacement oral, we don't crush it. You can't crush the pill. So if the patient can't swallow or it's too big, we can give them the liquid. For hyperkalemia, you can do sodium polystyrene sulfonate, which is Kayexalate, but it's going to take a little longer to start working because it has to get absorbed by the GI tract and it causes diarrhea. If we need something a little bit more quicker in an emergency situation, we can do regular insulin with dextrose IV. Okay. Next up is sodium. Sodium normal level is 135 to 145. What I want you to know about sodium, long story short, is that sodium equals neural. Okay, so you could think Na equals neural. Okay, so what does that mean? Your sodium level, it has a major effect on your neurological function. When sodium levels are too high or low, they have an effect on the brain and therefore they're going to lead to neurological symptoms. Also, sodium plays a key role in fluid balance and fluid volume. What does this mean? In short, water follows salt. Okay. What happens when you eat something very, very salty? You usually get very, very thirsty. Water follows salt. What happens when you're cooking something and you made it too salty? You're going to add water. Water follows salt. Anywhere in nature, water follows salt. In your body, it's the same. So, when a patient or a person has a lot of sodium in their blood, they're going to retain or keep a lot of water. This will increase blood pressure. So, that is why poor diet, such as a diet with high levels of salt, can lead to hypertension. And hypertension is considered the silent killer because high blood pressure, you usually don't know what's going on until it gets really bad. And the patient either has like a really bad headache or, God forbid, a stroke. And so it's very important to know the relationship between sodium and blood pressure. Also, it's very important to know the relationship between sodium balance and neurological functioning. So, hyponatremia, both high and low are going to lead to neurological symptoms. Diminished deep tendon reflexes, confusion, seizure, coma. Hypernatremia can lead to altered brain function. For now, that's all I want you to know. As we get more into cardiac, when we get to module 5, and also when we get to endocrine, I know that sounds weird, but just trust me for a little. You will see that it will make more sense when we actually learn the diseases associated with the sodium imbalances. But for now, memorize that sodium equals neuro because sodium imbalances cause neurological issues. And also that sodium levels play a key role in fluid volume. That water follows salt. The more sodium in the blood, the more water that's retained in the circulatory system, and the higher the blood pressure. Next electrolyte is calcium. Now, when you think calcium, I want you to think musculoskeletal because calcium levels have a major impact on your muscles and your bones, and also your nerves and your heart. So, low calcium levels. So, remember, for homework, you're going to have to read all of this. However, I'm just hitting on the major points that I absolutely know that you have to know for the NCLEX. There's a picture I'm going to show you in a little bit. So first up is low calcium. So what can cause low calcium? Maybe low calcium intake, for example. Maybe the patient has lactose intolerance where when they drink milk they or eat cheese, which are two major sources of calcium. Maybe it causes them to have diarrhea or bad stomach symptoms, so they don't want to drink milk or eat cheese. So this person may be at risk for low calcium intake, which can lead to hypocalcemia. Also, end-stage renal disease. So that disease process encourages low calcium levels in the blood. Diarrhea can also lead to that. So, assessment, I want you to know that when calcium is low, the patient can have something called tetany. And I'll underline that word for you. Okay. When calcium levels are low, the patient can have tetany, where they have these involuntary muscle spasms, paresthesias. And so, two that I want you to memorize are Trousseau sign and Chefestic sign. The treatment for low calcium is to give it. Okay. So, in a little bit, I'm going to show you some more notes that's going to help you memorize this. But just remember, low calcium can lead to tetany. And when you think calcium, think musculoskeletal because it can lead to these musculoskeletal issues like Trousseau sign and Chefestic sign. So Trousseau sign is when you put the blood pressure cuff on their arm and inflate it for 3 minutes, their hand starts to turn up involuntarily. It's like a contraction, a twitching that the patient is not doing on their own. Chefestic sign is when you tap their cheek and they twitch, their facial nerve twitches. They're not doing that. It's the nerves being irritated and hyperexcitable because of the low calcium. You need calcium for normal nerve and muscle and cardiac function. Then we have hypercalcemia on this side. Hypercalcemia, I have a saying for you in a little bit on another page I'm going to show you. Hypercalcemia can cause bone pain and stomach pain and kidney stones. Okay. So we're going to review that again in just a little bit. Next up is magnesium, 1.5 to 2.5. So read this for homework. I've got a little easier cheat sheet coming up in a little bit. Don't worry, but read all of that for homework. Phosphorus, here you've got your phosphorus. And remember, calcium and phosphorus have an inverse relationship. So when calcium is high, phosphorus is low. When calcium is low, phosphorus is high. So I've got a cheat sheet coming. So starting on page 78, you have a little bit of an easier breakdown of what we just reviewed. So please read it. So you're good with sodium. You know that that causes neural problems. Potassium, when it's too low, it can lead to PVC. So that's what a PVC looks like. Magnesium. For now, I want you to memorize 3 things about magnesium. When magnesium is low, it increases the risk for seizures. I want you to know that alcoholics may have low magnesium. Okay. And I want you to know the treatment for low magnesium is magnesium sulfate. High magnesium. I want you to know the antidote or treatment for high magnesium is calcium gluconate. Okay. For calcium, remember we said when you think calcium, think musculoskeletal. Low calcium leads to tetany. I want you to know that there are 3 surgeries that can lead to low calcium: thyroidectomy, parathyroidectomy, and laryngectomy. Why? Because on your thyroid gland, behind it, there's four parathyroid glands. The parathyroid glands regulate calcium levels. So when they are removed, either if the patient has a thyroidectomy or parathyroidectomy, calcium levels drop. A laryngectomy, which is also in the neck, can affect the parathyroids. So after these surgeries, if in an NCLEX question, it says the patient starts to have twitching around the face or mouth or hands, the appropriate action would be to check the calcium level. And if it's low, we give calcium gluconate. Okay. High calcium. It causes bone pain, stomach pain, and kidney stones, bone grown kidney stone. The treatments for high calcium, hydration to help dilute the calcium level, furosemide, biphosphonates, calcitonin, and in severe cases, dialysis. Okay, and that's it. Just memorize those things. Phosphorus, you know that phosphorus has an inverse relationship with calcium. That's all I want you to know now. Because when we get to endocrine in module 8, we're going to touch more on this. Because sometimes a principle is easier to learn when you associate it with a disease. Because then the symptoms of the disease, the manifestation of the problem, and then learning the treatment, I find that it works a little better for the students to understand it. Okay. So those are the electrolytes. Your homework tonight, or the homework this week, excuse me, is going to be about the electrolytes and also some other important topics that we're going to talk about. So let's take a 5-minute break. And my time on my computer is wrong, so it won't change, but let's take a 5-minute break. And then when we come back, we're going to learn some important aspects of the vital signs and then a fluid balance. I'll see you in 5 minutes. Thank you. All right. So we are on page 73. So, vitals. So, normal temperature should be 97.5 to 99.5. Celsius is there for you. And 98.6 degrees Fahrenheit is about 37 degrees Celsius. In my experience, if you ever see 38 degrees Celsius, that's too high. So when the temperature is too low, that's hypothermia. And that's not good because maybe the patient is exposed to an ambient temperature that is too cool, and that would slow down body function. Also, it could be a sign of sepsis. So don't always think like, oh, as long as it's a fever, it doesn't matter. No, low temperatures can be bad too. Too high is called hyperthermia, and this could indicate infection or overheating. So, all of these are problems that we don't want our patient to be exposed to. We don't want our patient to be in cool temperatures that are dropping their body temperature, because remember, your temperature is a reflection of your metabolism and your body's ability to make energy and use energy. So, if the temperature is too low, if the patient's core temperature is too low, their bodily functions can't occur properly, their bodily metabolic reactions can't occur properly. And so that can put them at risk for slipping into a coma. Also, it could indicate sepsis, which could be a very bad infection. So, these are things we have to keep in mind. And that's why, as nurses, we take vitals, and if they're abnormal, we report it to the healthcare provider so that we can start to get to the bottom of what's going on. Some tips: if the patient smoked, drank, chewed gum, or ate food in the last 15 minutes, check the temperature somewhere else than the mouth. So, oral temperature is, the most popular because you can check temperature orally in the mouth, you can check it temporally on the forehead. Tympanic is inside the ear. You can do axillary, which is under the arm. You can do rectal. Um, Oral is obviously the most popular. It's, the easiest sometimes. And but if they've had something in their mouth that could alter the temperature, check it somewhere else. Also, a patient on seizure precautions, you can't check the temp in the mouth, confusion or altered mental status, because you don't want that you put the thermometer probe in their mouth and they start seizing. They can, because their jaw might lock, and they can rip or break the temperature probe and end up swallowing it and blocking their airway. Confusion, same thing. You just don't know how altered their mental status is, and they can just bite the temperature probe and damage their mouth and their throat. Um, Patients with cardiac issues, seizures, diarrhea, GI bleed, a recent surgery of the rectum or prostate, or necrotizing enterocolitis, they can't have rectal temps. Cardiac problems, because the vagus nerve ends at the rectum. You put the temperature probe there, it can stimulate the vagus nerve, which would drop the heart rate. So, for someone with a cardiac issue, especially bradycardia, we don't want to check their rectal temperature. Seizures, you don't know when they're going to start seizing. They can start seizing as you're checking their rectal temperature. The thermometer probe can break off, and they can end up with a rectal tear, which can cause fecal matter to enter into the bloodstream and cause infection. Diarrhea, because that's going to alter the temperature down there, and we want accurate temperatures. GI bleed, the bleeding is going to alter the temperature down there. Recent surgery, we don't want to disrupt any suture sites. And necrotizing enterocolitis, you will learn when we get to peds, they're at high risk for perforation. Okay, pulse normal is 60 to 100. We're not going to go crazy for this right now because it's better that we devote that to cardiac. But just know that when it's below 60, it's bradycardia. When it's too high, it's tachycardia. The different pulse sites, that'll be part of the homework questions you're going to get. Um, but just know that there's different places to check the pulse. Carotid, brachial, apical, radial, ulnar, femoral, popliteal, dorsalis pedis, and posterior tibial. So just make sure you know where they are, okay? Respirations normal is 12 to 20. When it's too low, that's called bradypnea. When it's too high, that's called tachypnea. Blood pressure. So anything that I'm saying, I just want you to focus on those things. However, I still do want you to read the entire chapter. Blood pressure. Oh my gosh, let's see if I could say this word today. So you obtain a blood pressure by using a sphygmomanometer. Oh my gosh, I could never say that word. That is what a blood pressure machine is called. And blood pressure is measured in mmHg, which is millimeters of mercury. Normal, normal blood pressure, systolic. What I want you to focus on systolic is that it at least needs to be 90. If at least the top number of the blood pressure is 90, the brain can get oxygen. That's what I want you to focus on. Diastolic, we only worry about diastolic when it's too low. I just misspoke, excuse me, forgive me. We only worry about diastolic when it's too high. Please forgive me. We only worry about diastolic blood pressure when it's too high because diastolic pressure is when the heart is at rest. So it's concerning when the heart is supposed to be at rest, but it's overworking. So two things I want you to memorize for now about blood pressure. One, the systolic should at least be 90. Two, we only worry about diastolic when it's too high. In terms of restrictions, this last bullet point, so we can't check blood pressure on an extremity that is post mastectomy, has an AV fistula or shunt or central line. Also, for homework, review the new guidelines set by the American Heart Association for blood pressure. Keeping in mind that this is something that we're going to review in cardiac. But please just take some time and look at this picture and get an understanding of what the new normal is. When I was in nursing school, 120 over 80 was the ideal blood pressure, but now that has changed. Okay. So now that ideal blood pressure is a systolic less than 120 and a diastolic less than 80, right? And keeping in mind that as long as the systolic is at least 90, the brain can get oxygen. Oxygen saturation, so there's different types of pulse oximeters, okay? You have the alligator clip, you have the one for the neonates that wraps around their cute little feet, and then you have the finger probes, or they look like band-aids that you can wrap around a finger. So you obtain oxygen saturation by using a pulse oximeter. So those are pictures of pulse oximeters, and it's going to give you a number that is a percentage. 95 to 100 is the ideal. Too low is called hypoxia. So I want you to start to memorize that an early sign of hypoxia is low oxygen saturation. A late sign of hypoxia is cyanosis, confusion, and altered mental status. And a chronic sign is clubbing of the fingers and toes. For now, that's what I want you to know. All right. I know we're zooming through and we're doing really, really good. Let's take another 5-minute break, and then we're going to talk about fluid volume deficit versus fluid volume excess. These things that we are learning are the backbone of your nursing career and the backbone of your NCLEX success. So you're doing very well. So we'll be back in 5 and we'll get into this. Thank you. All right, guys. So fluid volume deficit versus fluid volume excess, very, very important. So the first thing that you need to know is that the two populations at greatest risk for fluid and electrolyte imbalances are children and the elderly. Okay, very, very important for you to know. Why children? So as adults, let's talk about us. As middle-aged adults, our bodies are like 60% water. Children, on the other hand, especially younger, like babies, their body is 80% water. So, because their body is made up of so much water, that percentage of water means so much. It's a majority of their body weight. Their their body functions performing properly depends on that 80% of water. So when it's not there, when it's not enough, it causes major issues. Okay. The elderly have less. So whereas like babies 80%, you and me 60%, elderly is 50%. So the elderly have less water to begin with. So when they lose it, it causes major issues. So babies, it's because they most of their body is made up of water. So most of their bodily functions depend on that water being there. So when it's not, it's a problem. The elderly is because they start out with less. And also the elderly, they're on a lot of medications that can drop their fluid volume, like diuretics and blood pressure medications and things like that. So just make sure you know the two populations at greatest risk for fluid balance issues are children and the elderly. Okay, especially when we're talking about fluid volume deficit. I also want you to fix a mistake that I made. Surprise, surprise. But hey, nobody's perfect, right? You just have to live and learn and keep growing. I meant to say fever. Okay, so another mistake. I'm so sorry, guys. I have to drink some coffee. I'm very, very sorry. This is what I meant to say. Fever right here. Okay. I need some coffee this morning. Okay. So fever, vomiting, and diarrhea increase the risk for dehydration. Okay. So fever causes fluid to burn up because fever is associated with a higher body temperature. So the higher the body temperature, the more fluid your body is burning off. And so that leads to dehydration, vomiting, and diarrhea. You are physically losing fluid and that increases the risk for dehydration. So, what's the big picture? Children and the elderly with fever, vomiting, or diarrhea are at extra high risk for dehydration. Fluid volume deficit. Another word for that is hypovolemia or low fluid volume. The major causes dehydration, excess output like vomiting and diarrhea, and blood loss. Fluid volume deficit, the problem with this is that it can lead to shock, and shock can lead to death. Shock, the body doesn't have enough fluid volume to keep the body alive. What keeps your tissues alive? Oxygen. How does oxygen get to the tissues? The blood. So when you don't have enough when you don't have enough fluid volume circulating in your circulatory system, you can't bring the oxygen effectively to the tissues, and then the organs die. Okay, so memorize shock. The body doesn't have enough fluid volume to bring oxygen to the organs to keep them alive. This can lead to something called multi organ dysfunction syndrome or MODS. Also, memorize the number one problem with shock is decreased tissue perfusion. So, remember, there's not enough fluid volume. Maybe the person lost too much blood. Maybe the person has been vomiting or having diarrhea or has had a severe fever for so long that their fluid volume in their blood vessels has reduced to the point where there's just not enough blood to bring oxygen to the brain. That's what we call decreased cerebral perfusion, or not enough to the lungs, decreased pulmonary perfusion, not enough to the liver, gallbladder, or kidneys. This would be decreased liver, gallbladder, or renal perfusion. So when organs don't get enough oxygen, symptoms start to pop up that give you signs like, hey, something's wrong. So when the brain is not getting enough oxygen, that's where we get altered mental status, confusion, and eventually coma, which the patient might not come back from if we don't increase the fluid volume and oxygen level, decrease pulmonary perfusion. So when the blood or when the body doesn't have enough oxygen, it tries to compensate and make the person breathe faster. Like, okay, there's not enough oxygen in the blood. Let me breathe faster and get more oxygen in. Okay. And so that's why tachypnea is associated with respiratory distress. Okay, which is also associated with shock. Decreased liver perfusion. So when the liver is not getting enough oxygen, it's going to let you know by these two lab levels, ALT and AST. They'll be elevated. That's the body's way of saying, hey, something's wrong with the liver. When the gallbladder is not getting enough oxygen, elevated bilirubin and decreased renal perfusion, you're going to have elevated BUN and creatinine and decreased urine output. You have to memorize this entire section. There's no way around it. The other thing I want you to know, we're going to skip this section for one moment and go to where it says sepsis. Sepsis is related to shock, but it's dealing with an infection. Okay, so shock can happen because of blood loss. Okay, it can happen like cardiogenic shock, where like the patient has a heart attack and the heart is not pumping blood. And so the organs don't get oxygen. Okay. So shock can be because of like a mechanical problem or an allergic issue, like a bee sting or something like that, leading to anaphylactic shock. But either way, shock, there's not enough fluid volume and the organs don't get perfused. Sepsis is dealing specifically with an infection. So I want you to know that difference. Okay. So sepsis is a severe infection has overtaken the body, leading to hypovolemia, and it can lead to septic shock. So I want you to know there's shock and then there's septic shock. Okay. Treatment, oxygen. Remember, the number one problem with shock is decreased tissue perfusion. The tissues aren't getting enough oxygen. Give oxygen. Then, number two, we give IV fluids because the problem with shock is we don't have enough fluid volume. So, we need to replace it. So, we give oxygen, we give IV fluids. For sepsis, we're going to draw blood for blood cultures to see what is growing in the blood causing the infection, and we're going to give antibiotics. A lab level you can check for sepsis is called lactic acid. Okay, so remember for shock, oxygen, IV fluids. If it's sepsis, you also, in addition to oxygen and IV fluids, you draw blood for blood cultures, you give antibiotics. You always draw the cultures first before you give antibiotics, and you can also draw lactic acid. I want you to memorize the vital signs of shock. It's low blood pressure, high heart rate, high respiratory rate. Sepsis, you might see a high temperature. Okay. Okay, guys. So I'm sorry if there's a glitch in the internet connection. But so the vital signs of shock, make sure you memorize those and understand that with shock, the blood pressure is going to be low. So we need to give IV fluids. The heart rate is high because the blood pressure is low. So when we give the fluids, we'll fix the blood pressure and normalize the heart rate. The respiratory rate is high because the body's trying to get more oxygen. So we give the patient supplemental oxygen to help them. Okay. All right. Last topic of today is fluid volume excess, which is also called hypervolemia and is associated with fluid retention. So, some major causes: CHF, congestive heart failure, chronic kidney disease, and end stage renal disease, and also low levels of albumin. We'll talk about albumin when we get to module 7 and talk about GI. Okay, so anasarca, if you see that word, that means the patient has edema everywhere, and you are going to need a lot of chucks, the pads that absorb fluid under the patient. So, assessment, I want you to know that the pulses are bounding and difficult to obliterate on palpation. That means when you put your finger to check their pulse, like if you press down, it would be really hard to hide that pulse because it's so bounding because there's so much fluid in the blood vessels because of the fluid volume excess. The more fluid in the blood vessels, the higher the blood pressure. Also, when fluid runs out of places to go, it goes to the lungs. Okay, so they may have crackles and shortness of breath, orthopnea, which means they get short of breath when they lay flat, and jugular vein distension, which means blood is backing up from the heart and entering into the neck veins. Dependent edema, where their lower extremities can have edema, ascites, fluid in the abdomen, and third spacing, where fluid goes into body cavities and increased body weight. So interventions for fluid volume excess would be to weigh the patient daily, same time of day, after the patient wakes up and they pee, weigh them each and every day so we can monitor their fluid retention status, monitor their abdominal girth, if they have ascites, which is that fluid buildup in their belly. And we're going to learn when we get to GI and we learn about cirrhosis that ascites can make it more difficult to breathe. So just like when a woman is pregnant, she gets really short of breath. Um, as the abdomen fills with fluid, or a baby, it increases the intra-abdominal pressure and that decreases the ability of your diaphragm to expand. So as the belly fills with fluid, it makes it harder for your lungs to expand, and that could lead to respiratory distress. We want to keep a patient with fluid volume excess and semi-Fowlers or high Fowlers to promote proper ventilation, elevate the legs if they have edema. Diuretics may be ordered to help remove the excess fluid from the body. Monitor blood pressure because we don't want to uh, have a stroke. We don't want the patient to have a stroke. Okay, so today was a lot. Today was a lot, a lot, a lot. But that's all right because what I want you to do is I want you to study. I want you to read the chapter. I want you to review this once the recording is released. I want you to review it. I also want you to use your flashcards. I have a flashcard set for electrolytes. So remember, because class is ending today, I'm going to make it up to you and I'm going to release questions for you on Thursday. And I'll send you the link in the WhatsApp group. Also, when the recording of this video is up, I will send that as well. It's going to be the clickable link again, and everything from day one will be there for you on that link. So, we're going to go ahead and play the video for isolation precautions. And Also, I'm going to add on the lab level values video for you to be playing every day as well. So these are things that if you're doing them every day consistently, doing one or two things to study for your NCLEX, like tomorrow, watch this video again. Then the day after, read the chapter. Then do your flashcards. Then do 25 to 50 questions. Then do the questions I'm going to send you. These are behaviors and habits that will increase your chances of passing the NCLEX. All right, so I'm going to play the video and then after that, you are free to go. Thank you so much for spending time with me. God bless you, and I will see you next week. Thank you so much.